So we have a few minutes left before we move on to the next topic. And I primarily want to open it up to see how people approach IBD. Are there anything else added? Bill, you've been involved in some of these pathways, and anything else you want to add in terms of the approach, severity, stratification?
No, I think what you were sort of alluding to earlier, that just exactly what the risk models are that should pick the patients who have a bad prognosis are still evolving. Marla's been involved with that with Corey Siegel quite a bit, and that approach they have for Crohn's disease is promising. So identifying early through your clinical judgment, all the things that Jessica was talking about, like terrible deep ulcerations or some of the predict models and stuff are all things to help you pick the patients where you really have to go for highly effective therapy.
Great. And
these unique cases, if you have a major dermatology complication, whether it be psoriasis, that which we see along with IBD, not just as a complication of anti-TNF therapy, that goes really well with interleukin 12/23 or in the future interleukin 23 drugs. If you have arthritis, a TNF blocker or a JAK inhibitor will work well. Sometimes you see pigmentation disorders or autoimmune alopecia. JAK inhibitors work nicely for that. So you can really dial in and out along the extraintestinal manifestations some of these specific pathways.
Yeah, and I think it's important because this isn't just bowel inflammation. We all know this. We see this in our clinics. This is really a systemic inflammatory process. Marla, I'm going to ask one question to you, and then I'm going to give the final word to David. But, Bill alluded to the Corey Siegel work and kind of looking at prognostication. Maybe touch on that for a minute, and then, David, I'm going to ask you for a wrap-up.
Bill alluded to, one of our biggest concerns is when someone presents with symptoms or signs that we don't deem, oh, we need to rush you to a biologic, for example, because you've got bad perianal disease, or some of the more obvious things that Jess also mentioned. I think that's less the issue, but that's only a certain proportion of patients. So how do you take patients that we may have caught early or who are actually, especially Crohn's, say, I'm feeling okay, I'm just, why are you rushing me to an anti-TNF or a biologic at this point? And that's where the objectification of predicting severity rather than waiting for a patient to actually present with a complication, I think is how we're going to match I say the punishment with the crime. You need to be able to say to a patient that we are predicting your prognosis will be that there's a very high likelihood you're going to complicate, you're going to need surgery. And we have a way of slowing that down or maybe completely changing that natural history by using effective therapy. So I think we wanted to get out there with Crohn's because we felt that disconnect between sometimes symptoms and prognosis are more evident. And of course, moving next to developing something similar. The goal of what Bill is talking about is we had published about something called Prospect, which is a risk prediction tool that actually uses a interface that you can show a patient their personalized risk, because what also became clear is that it's hard to individualize IBD management unless you actually use that person's individual risk factors and show them visually that this is about your disease and not the 100 people that may have told you I did fine on this therapy. It's really important to individualize. And I think predicting who's going to need what therapy is step number one, and then predicting which therapy, which Bill did allude to a little bit, and I'm glad that he started talking about the presence of extraintestinal manifestations. I think we have to understand that genetics are such a powerful role here, especially in those who have, for example, psoriasis, or a strong first degree relative with psoriasis or some of these other extraintestinal manifestations. Understanding that some of our candidate genes may actually also be tied to which therapeutic target we should go to first. Because I think we all agree on this call that the first therapy is probably the most important. And if you could get that right, that's really going to change the natural history.
Great. So thanks, Marla. So David, we've covered a lot in a short amount of time. And if you were to give us your top 3 tips or top 3 or 4 tips that you heard and from this discussion, what would they be?
Well, we first of all acknowledge that there are millions of Americans who are suffering from inflammatory bowel disease and many more around the world. And we don't yet know the cause, but we've learned a great deal about the individual variations of the disease and its presentation, and that this chronic condition needs considerations, not just how we address the patient when they're initially sick, but also when we think about the long term for them. And we can use risk factors and additional features of their disease, like extraintestinal manifestations, to help us understand what their individual risks are for complications or poor outcomes, and therefore make appropriate treatment decisions. We're now at a phase in managing IBD after all these years where we must be more proactive in thinking through these things. And I think that my colleagues have really made a nice case for us understanding this more, and it really is the standard of care for IBD.